to welcome us all. Feel welcomed as we want to tackle one of the conditions which has become very common, and we would like to get to know more about it. And today we will have a survivor giving us her personal experience with ovarian cancer, and as well as having a clinician giving us the medical aspect of ovarian cancer. So I take this opportunity to welcome all of you, and feel welcomed. Let us be as interactive as possible. If you have questions, if you have questions, they're not restricted. You can put them in the chat box. You can as well unmute when we ask for that time of unmuting and asking the questions. And remember, put your phones on silent. Only unmute your line when talking so that we minimize any interruptions. So I take this opportunity to welcome Faith Bonaya. Faith, feel welcomed. It is your time. I welcome you to come and speak to us about your experience with ovarian cancer, and feel very welcomed.
Thank you.
Welcome.
Asante sana. Kwa majina naitwa Faith Bonaya. Niko na miaka 34. Nilikuwa diagnosed na ovarian cancer mwaka wa 2012. So before nijue ni cancer, nilikuwa nasikia, yani most of the times nasikia tumbo ikiwa imejaa, nasikia sina hamu wa chakula, halafu nasikia niko na uchungu mwingi sana katika tumbo langu la chini. So iliendelea hivyo for some time, but nikaamua kwenda kuseek medical attention. So nikaenda kwa hospitali inaitwa Kenol Hospital. Kwenda hapo niko na growth kwa ovaries, both of them. So akani watoe kwanza, then wazipeleke ziende zikapime that growth, waone shida iko wapi. So nilifanyiwa operation, wakatoa hiyo growth, wakapeleka ikapimwa. So kurudi results nikaambiwa niko na ovarian cancer. So nikakuwa referred Kenyatta Hospital. So nikakuwa admitted hapo, nikafanyiwa chemotherapy section 6. So after that nikaendelea vizuri na review. Kila nikipima niko sawa. So after that I think in 2014 ikielekea kuisha, ndio nikaambiwa so sitakuwa naenda that frequently unless nisikie niko na shida yoyote, ndio nitakuwa naenda kwa check up. But I thank God cause niko sawa mpaka saa hii. Nakaa nikienda kupimwa the normal nini ambayo naendanga after a period of time, but napata niko sawa mpaka saa hii. But during that period challenges zilikuwa nyingi, madawa, ilikuwa stress, halafu pia watu vile wanaichukulia, it was very bad. Lakini I thank God, maana Mungu ni mwaminifu. My family walisimama na mimi, nikapitia that situation. Challenges hizo zote walikuwa hapo kunipatia roho, na nashukuru Mungu maana mahali nimefika it is only God. Na nashukuru Mungu because there is a great testimony after that. Niliugua nikamaliza, after kuwa discharged niliconceive na nikapata mtoto after hiyo period yote na hiyo ugonjwa wote, na nikafanyiwa hiyo process yote chemotherapy. But I thank God paka after that Mungu alifanya miujiza, maana bado nilipata mtoto after hiyo situation.
Wow, that is very powerful. Asante sana Faith. Asante sana Faith. Kuna swali kuhusu vile Faith ametueleza kabla hatujaenda kwa our next presenter. Any question? Any question? Labda Faith, kabla hujaondoka, ningependa kukuuliza ya kwamba ili kuchukua muda gani ili uweze kujua kama uko na shida kama hiyo? Faith, umezima? Hebu unmute.
I'm sorry. So nasema ilikuwa hiyo situation, yani napata tumbo imejaa, pengine hata sijakula anything, yani ilikuwa inajaa mpaka nasikia it's like yani ni chungu. So ilikaa hivyo kwanza the time yenye ilianza kunifanya hivyo, so nikakaa for around 4 months ndio nikaanza hizo appointments na gyna, nikakuwa natembelea gyna, nikaona haitanisaidia, so nikatake that opportunity, nikaenda sasa hii hospitali Kenol Hospital. So kuenda kupimwa ndio nikapatikana ni hiyo. So hiyo period ilichukua around 3 to 4 months ndio nijue nina cancer.
Faith, asante sana kwa kutueleza jinsi ulivyoweza kujua ati hiyo ni kansa. Kabla hujaenda hospitali, ndio iwe ulikuwa na hiyo ovarian cancer, kuna njia yoyote ya matibabu ulijaribu?
Hapana, nilikuwa tu venye ilikuwa inajaa, so nikienda hospitali ile tu unaambiwa maybe tumbo imeharibika sababu ya chakula, vitu kama hizo. So the more unaenda hospitali unapata unaambiwa ni hivi ama hivi, unapewa hizo antiacids, vitu kama hizo. Nikaona imekuwa worse sasa. Ndio sasa nikaenda sasa hiyo hospitali, lakini hii ingine nikienda hospitali ndio napewa tu antiacids, hizi madawa tu za kurelieve hiyo kujaa kwa tumbo. Hakukuwa na matibabu mengine yoyote nilipata.
Okay, na baada ya kugunduliwa na kuanzishwa matibabu, ilichukua muda gani na matibabu?
Nilianzishwa matibabu 2013 February. So nikapewa session 6 za chemo. So that it was around 6 months hapo. So nilikuwa napewa nilikuwa first section, naenda kwa nyumba, narudi nyumbani, nakaa, narudi after like 3 weeks. So narudi tena hivyo mpaka nikamaliza section zote 6.
Wakati ulikuwa unapata hiyo matibabu Faith, ulikuwa unapata ukirudi nyumbani ama ukilazwa hospitali?
Nilikuwa nalazwa hospitali.
Kwa muda gani?
Nilikuwa nakaa hospitali for 1 week. Naam.
Asante sana Faith. Does anybody have a question for Faith before we welcome our next presenter? Mtu yoyote ambaye akona swali, lakini najua bado tutapeana nafasi ya kuongea zaidi juu ya hiyo. So Faith, kaa tu, unaweza tu kumute line yako alafu tuweze kupata mnenaji wa pili ambaye ni Anthony Mushiri. Anthony, I'm not sure if you have already joined us. So you can unshare your screen so that Anthony can share his. So I take this opportunity to welcome Anthony Mushiri. Anthony Mushiri is a clinician at the International Cancer Institute, which is based in Eldoret. Anthony has gone through training of medical oncology, and he is a very key person at the Care and Research Clinic at the International Cancer Institute. We all rely on him on the diagnoses that are being made. And even most patients who have passed through International Cancer Institute knows what Tony is able to do. Very passionate, very learned, very understanding, and able to reach out and act even in the most critical situation. Someone who can take up responsibility with very little resistance. Welcome, Tony.
Well, thank you, Pamela, for the wonderful introduction and the kind words. It's a pleasure for me to be here, and more so the ability to share this knowledge, which is very valuable for the public and even for the patients, and even learning from each other. I can see esteemed colleagues as well in the attendees. So I believe it will be a very interactive session, but putting in mind, I try to really simplify it for the mixed group of audience that we have for today. So thank you all, and I will probably engage you for the next few minutes in the topic of ovarian cancer, mainly just being an overview of the topic. And as you are all aware that next month, it's Ovarian Cancer Awareness Month. And what better way to usher the month than sharing this valuable information with all of you present here today. So some of the objectives that we have today in terms of the webinar for today, basically learn the basics of ovarian cancer or even evaluation of ovarian masses, review the risk factors for ovarian cancer, and even probably some of the protective factors that could be preventative for ovarian cancer. Again, we'll touch on the evaluation and diagnostics of ovarian cancer, and also touch a little bit on the treatment and even prognosis of ovarian cancer, and even matters pertaining to what happens post treatment and even the issues of survivorship. So like I had hinted earlier, this will be a very easy to understand session, hopefully. And I will ask that if for one reason you'd want me to mix up the languages, maybe switch to a bit of Swahili and English, I'd really be open to that. But I hope to use the most simple language possible. So as a start, we all need to understand where the ovaries are and what the functions of the ovaries are. And as you can see in the pictorial above, this is the female reproductive system, or part of it rather. And well, it is composed of a group of organs and mainly for sexual reproductive purposes. And so the ovaries basically are situated in the pelvic area, just at the middle, just beside the uterus, as you can see. Let me just put a point on it, sorry. So these are the ovaries here. As you can see, they're on both sides of the, beside the uterus, that is. They are small sized, actually like a grape. And as you can see, they are lined by these tubes, which are called the fallopian tubes. And then you have the uterus that normally carries the pregnancy. And then you have the cervix here, as well as the vagina. So these tumors of the ovary, they can involve the ovary itself, and even the tubes, or even, though these are different entities, they can also go to the uterus itself. So what is the work of the ovaries? Normally, the ovaries are very useful in production of, I would call them the eggs that are fertilized, and later you have the pregnancy occurring in the uterus, in simple terms. So I will just touch on this very lightly. And we have 3 types of ovarian cancer. Mainly the main one is epithelial, and these are tumor that starts in the linings of that, sorry. So it's a tumor that starts on the outside of the ovary, and it's the majority of the ovarian cancer type, actually about 80 to 90%. And you have these other 2 subtypes that are sporadic, and they normally occur in the younger age, because you'd expect for this epithelial type, normally the age that is given is the age of about 50 years, being the commonest, and like I'd hinted, is also the commonest type. The others very sporadic, about 1 to 10% of the cases that we normally see at the clinics, without going much into the specific and bore the other audience. So I will go straight to the Kenyan picture and what we see. And normally we have what we call the global can. it's a global body that does data and estimates on the number of cases of specific cancers in different regions across the world, and even estimates on what we should expect in terms of maybe mortality, that is the deaths, and even the prevalences. And so for this one, the Globocan Kenya facts sheets, these are the data from 2020. And as you can see, from the Kenyan side, they estimated to have at least 11,000 cases. And that was about 4.2% of all the gynecological, the female cancer that we saw during that time. These are rather busy slide, but you can just visualize the area that is highlighted here. You can see at the rankings, ovarian cancer is at number 9 in terms of the cancer that we see in the country. And then see the number of deaths. Out of the 1,100 cases, you can see about 800 cases more or less don't do so well. And then this is the accrued number of prevalence in a 5-year period. So you can see it's quite a significant number, because if you could imagine 11,000 people in 1 year, that's a big number. And we'll talk more on why it is significant that we raise our voices today and educate each other on ovarian cancer. So next, I want to touch on the risk factors for ovarian cancer. Of course, there are many, but these are the main ones that are really highlighted, and especially the first two. And they say any woman above the age of 50 years, then she's at a risk for ovarian cancer. And then you have persons who have a family history of having cancer or ovarian cancer, breast cancer, even stomach cancers, generally just genetic predisposition. And that includes these, what you call the hereditary symptoms that put a certain individual at risk, being that there's a genetic inheritance going on in that family. And one of the examples is this thing called Lynch syndrome that normally gives ovarian cancers, colon cancers, and gastric and even breast cancers. And that also includes genetic mutations, such as this gene called BRCA, or the BRCA mutations 1 and 2. If that is seen to be positive, then most likely there's an increased lifetime risk of getting ovarian cancer. Some of the other risk factors include persons who have attained early menarche, that is attaining periods at a very tender age, and those who attain menopause at a very late age. So you find these people have prolonged exposure to some hormones that would put them at a risk of having ovarian cancer in future. Then you have people who have not been able to bear children for one reason or the other, what we call nulliparity. They are also at an increased risk of ovarian cancer, late childbearing, and even a condition called endometriosis. Remember, all these are risk factors, and they do not necessarily mean that you will get ovarian cancer eventually because you have one or the other. Another point I want to stress is that as much as we mentioned the issue of the genetic risk factors being a major part of the risk factors, remember most of the cases we see, they are actually the sporadic types, which are more common in our setup here. But then safe to say that in our country, as much as we are evolving, we are yet still to have these genetic testing clinics or even counseling being done for our population, but it's something that probably we can discuss at the end with some of the colleagues available on this panel. So I also hinted that we'd be talking about some potential protective factors that would probably reduce your risk of having lesser chances of having ovarian cancer. And some are very drastic, that would include surgery. That entails removal of the uterus, fallopian tubes, and even the ovaries themselves, issues of tubal fallopian tube ligation. Breastfeeding has also been shown to reduce the risk of ovarian cancer. And by this, they mainly reduce the those harmful hormones that would actually give you the risk for ovarian cancer. Then you have the issues of parity or the number of children you have. Actually, some data shows that the more a lady has conceived and given birth, probably it would lower chances of getting ovarian cancer. The other protective factor would then be hormonal contraceptives. The combined oral contraceptives have been shown to have some risk reduction in them. So you might ask, why did I say that some hormones can lead to ovarian cancer and not? Somebody kindly mute Penina Mutua. So some hormones are harmful, yet for others, they're actually protective. And that's why you find some women who have had the use of hormonal contraceptives, the combined ones, have a reduced risk of ovarian cancer. But yet on the flip side, the use of those similar hormonal contraceptives would probably lead to other types of cancers. So it's a tightrope that it's a yes and no, but this needs to be discussed with the primary physician and determine what is best for you. So the next slide is on the clinical presentation, or the picture that would expect for an ovarian cancer patient. Also, I would call it AKA signs and symptoms. And it's quite what do I call it? Ironical, because for ovarian cancer, it is largely very asymptomatic. Just like the first case, the survivor talked about her symptoms being actually quite vague and mundane. And as you can see from the first statement, they are usually very asymptomatic until when you have this very advanced disease that you'd expect to see some of these symptoms listed here below. So a common phrase that is mentioned now and then is that ovarian cancer has whispers. And we just have to be keen on those vague side effects, not side effects, signs and symptoms that would indicate something is actually wrong. And in our setting, I'll start with what we see practically and go to what would make you suspect that indeed all could not be well. So some patients present, like I've listed on the left side of the screen, what we call the acute or the emergency presentation. And these patients will come with the abdomen being distended or swollen, and you might find some fluid in the abdomen, what we call ascites, and will cause discomfort to the patient, including pain, discomfort, issues of feeling full all the time. And some patients will actually come with issues of fluid in the lungs, what we call pleural effusion, and that will give you chest symptoms. That might be a persistent cough, chest pains, difficulty breathing. And then some patients will come actually with a bowel obstruction. And these patients will actually have signs of nausea, vomiting, maybe difficulty passing stools, feeling just full, just basically having this great discomfort in the abdomen. And in some rare cases, you might find patients with these signs of swelling, maybe in the limbs, because they have clots in the blood vessels there, which are quite painful, or even to the lung area, which could be very serious. So on the right side of the screen, there are the other symptoms that I would call not emergency as per se or acute. And these are some of the symptoms that I had hinted earlier. That some might be very vague, that if you see them, probably it's something that should maybe see a physician and have a thorough exam and maybe rule out some of these nasty things that would be possibilities. And this would be patients who present with pelvic and abdominal pains, frequent bloating and abdominal discomfort, and even sometimes swelling. If you are going to the loo multiple times, you have increased urine frequency and even urgency. You have very poor appetite. Every time you're feeling full or when you're trying to feed, you get full very, very fast. You have nausea, and then issues of anorexia as well. Those would be symptoms that would tend to worry you. In terms of the signs, sometimes you can even palpate a mass in the abdomen once your doctor checks you out. So what entails the evaluation for patients with I don't want to call it ovarian cancer, but I would want to call it ovarian masses. So one, you get the symptoms we talked about. You have gone to your doctor, just like our first survivor talked about her presentation. She was feeling full all the time, some abdominal discomfort and all that. So you go for an evaluation, and this time the initial is to check out for the likelihood of having the ovarian cancer. And you'll have a physical exam done. Of course, it will be very detailed. I'll show some pictures on the subsequent slide on the physical exam. And then you have, if they have concerns for further investigations, the doctor will also order you to have a pelvic ultrasound, or preferably what we call a transvaginal ultrasound, which is more accurate for ovarian masses. At the same time, they might take some blood labs, and these they check for some things we call tumor markers. So tumor markers are chemicals or biochemicals produced by certain tumors in our bodies that could suggest you have a certain type of cancer. So tumor markers are important because, yes, they can point us in the right direction. Two, they can be used to evaluate how the treatment is going on the treatment phase as well. But remember, tumor markers are not like definitive or diagnostic of cancers. Kindly mute your mics if you are not asking anything. Okay, so from these two previous investigations, the physical exam and the imaging, the ultrasounds and the labs, one, you might get what you call an adnexal mass, or a mass in the ovary or even around that area. We call it adnexal mass. And you have these elevated tumor markers, and in particular, what you call CA125. Some of you will be familiar with it. In most of the cases, when you have these two, there's a very good chance of about 80% that indeed this could be ovarian cancer. Remember, I said the tumor markers are not very diagnostic of cancer, in as the sense that for other reasons, you might also have elevated CA125. That might be even when one is pregnant, issues of endometriosis, and even other issues that might give you elevated tumor markers, such as CA125. But remember, there's that big probability of about 80%. And so at this point, probably I would want to ask maybe the clinicians who are on this. Once this is seen, kindly refer that patient to a gynecologist or oncologist who will evaluate further for ovarian cancer. And for this, the doctor will want to evaluate for disease spread to determine the extent and even suitability for surgery. So this determination of suitability and the extent for surgery will include evaluation, CT scans, MRI, and even checking the fluid, either in the lungs or even in the abdomen, whether it is having some cancerous cells, and you might even request for a biopsy or even an FNA of a suspicious mass just to evaluate that. So I talked about physical exam, and as you can see from these two images in front of you, one is the pelvic exam, which is really key for any patient who is having symptoms concerning for ovarian cancer. So a pelvic exam, we normally check one, starting from the external of your reproductive system, that is the outside of the vagina itself, and the cervix. We'll check how it appears. And then subsequently, now the doctor will actually feel for any masses in that area of the ovary. So I know it looks quite disturbing or uncomfortable because of the nature of the intrusiveness of the procedure, but it is very essential that you have it. For sorry, somebody just mute that person. Yeah, so like I said, the doctor will feel for abnormal changes in size, shape, and even the position of the ovaries and the uterus, and even any suspicious masses at that point. And like I said, some instrument is used, and I think most of the women here will attest to an instrument they have had being called the speculum that might be used during the procedure. So like we said, it's a very necessary procedure, uncomfortable, but very, very necessary. On the right side is what we call a transvaginal ultrasound. And an ultrasound is an imaging modality that normally uses sound waves in your body to make images of parts of your body and see whether there's abnormalities or not. So for this transvaginal, there's a probe that you can see is inserted at the vagina to better access and assess the organs in that pelvic area. So ultrasounds are normally very painless, harmful in that they don't have radiation. You might get a little bit of discomfort due to the intrusiveness, but otherwise it is a very safe procedure. Actually, both of them, they should be very safe, very simple, but yet life-changing in the terms of diagnosis. So like I said earlier, once you identify that indeed there's a likelihood of ovarian cancer, the patient is referred to a gynecologist. So the gynecologist will want to see what stage is this patient at. So in cancer, basically, we talk about 4 stages of cancer. So you have stage 1, 2, 3, and 4. 1 being when the cancer is at the place of origin. 2 being when the cancer has spread but still localized within that neighborhood of the primary where it started. And 3, when you have the disease that has spread but not yet very, very far away. And then 4, you have disease that has gone to distant organs around. And so in the context of ovarian cancer, so you have a stage 1 disease whereby the cancer or the tumor is still found in one of both ovaries, but it is contained within it. There's no spillover outside the ovaries, okay? And then for stage 2, you have a cancer that now, apart from being in the ovaries, it is spreading to other parts of the pelvis, such as the fallopian tubes and even the uterus itself. Stage 3 is when you have the cancer now going all the way from the ovaries, spreading to the pelvis, and then outside the pelvis to the nearby, what you call the lymph nodes, and even to the linings of the intestines or even the liver. So that is a stage 3 disease. And then stage 4, like I had hinted earlier, is when the disease has spread from the ovaries outside the pelvis, now extending beyond the lining into the liver itself and into the lung, bone, or any other organ that the cancer might spread to. Why is this very important? It is important because the cornerstone of treatment for ovarian cancer is mainly surgical. And one, it is for diagnostics to actually determine indeed it is cancer, and 2, to stage it, and 3, to give what we call the grade. The grade is it's a parameter measured by the pathologist that determines how aggressive cancer cells are and how possibly the disease could spread faster or even slower depending on the grade. So the standard for all cancer management is that all teams must be involved. And for this case, you have the gyne oncologist leading the team. Then you have the pathologist, you have the radiologist doing the CT scans, you have the nurses giving the treatment, you have the navigators linking all this team together, you have the counselors. Every aspect of the team is really key to this patient. Like I had hinted earlier, the mainstay for treatment of ovarian cancer is surgical. And apart from the other goals of the surgery, the ultimate goal is to remove as much cancer cells as possible. And in ovarian cancer, then that entails possibly removal of both ovaries, the fallopian tubes, the uterus itself, and even sometimes the appendix and some nodes that are around there, just for us to get as much tumor out as possible. So what happens after surgery? Then that specimen or that tissue is normally sent to the pathologist who I talked as being part of the multidisciplinary team, who then confirms the grading, the extent of the tumor, and then that will advise on the next steps of care. And that usually what we call chemotherapy. Normally, a drug which is injected normally for a period of time, normally on a frequency of every 3 weeks with subsequent evaluation. So this chemotherapy is normally to consolidate what was done during surgery. It's like a mop-up or just sweeping up any remaining cancer cells in the bloodstream. In some cases, you might also get what we call radiotherapy, which I've not listed here, if the gyne-oncologist feels the need for the same. Apart from that, we have
Please
other.
mute your line in case because you're not the one talking, so that we can get maximum attention.
Apart from chemotherapy, we have other new agents coming on board nowadays, and we have what we call immunotherapies. Immunotherapies are molecules or drugs that use the body's defense system to fight cancer cells, in simple terms. And we have these options now available in the countries for persons who have exploited chemotherapy and surgery, and they would be candidates for immunotherapies. And case in point is for persons who have tested positive for some certain genetic mutations, such as what I talked about called the BRCA1 and 2 mutations. They would really be candidates for what we call immunotherapies. Other category of treatment that we have is, of course, hormonotherapy and fertility sparing therapy, such as the ovarian sparing surgeries that would restore a woman's fertility after the treatment, just as our first survivor had spoken about her having all the treatment and later having ability to conceive. So what happens after your treatment, or what you call the surveillance phase? So you'll be followed up for a certain duration of time. Of course, for all stages, not just stage 1, stage 2, 3, or 4. For all stages, you'll have to have follow-up. And for the first 2 years, we advocate for follow-up every 2 to 4 months. Of course, during these visits, the doctor will have a physical exam, imaging if needed, pelvic exam, we'll have a blood test collected, the tumor markers that we talked about earlier, and even genetic risk evaluation for those who are found to have one at some point, and even the long-term wellness care. After the first 2 years, you'll have a continuation of surveillance and clinic visits or schedules every 3 to 6 months, depending on your doctor's inclination or discretion. And after every 5 years, you'll have an annual checkup with your oncologist. So all the above, the pelvic exam, physical exam, imaging, CBCs, CA125 and the rest will be done during those visits. And of course, there's that chance of, God forbid, developing another cancer that can be identified at this point during the follow-ups, or even risk of recurrences and relapses. This will be identified during this scheduled for follow-up. So I'll also talk, as I go towards the end, on issues of survivorship. So survivorship is really key in cancer care. And that begins on the day that one is diagnosed. It will involve the multidisciplinary team, as I talked about, and it involves the physical, emotional, psychosocial, and even financial issues that are very unique to cancer patients. And,
Please mute your lines so that we can listen to what is being taught.
Yeah. And at this point, I would want to mention especially about the issue of palliative care. And this is the holistic care for cancer patients, be it whatever stage, whatever treatment they are getting. It's very key that it started at the beginning, and this will go all the way into addressing the long-term treatment side effects, aligning the clinic schedules and tests for the patient, linkages with the support groups, and even counseling on healthy lifestyles for these patients. So I believe that was my last slide. These are my references for the information I've just given. And then I will wind it up at this quote that I found. So ovarian cancer symptoms whisper. And because my daughter listened, I'm able to make a scrapbook page instead of a memorial page for her. And that is the strength of listening to those very vague symptoms that would think typically just any other thing and not cancer. So I would urge for all the women here, maybe your spouses, your daughters, kindly just extend a word of knowledge and mention some of this knowledge I've gained today. Help us to raise the voice on the signs and symptoms of ovarian cancer so that we can have early diagnosis, timely therapy, and even better care. Remember, for every stage that is worse than stage 1, the prognosis or how well a patient does actually reduces by a significant amount. So how a patient in stage 1 will live for, or probably have a good life, will be very different from one who is at a stage 4 disease. So my pleas, let's listen to the whispers, let's communicate to the doctors. Whatever you feel is very vague, just communicate. So thank you. Over to you, Pamela, and I'll be happy to respond to any questions from the attendees and team.
Thank you very much, Tony, for that very elaborate presentation on ovarian cancer. I would like to, before I give a few comments, I would like to open the floor for any questions or any comments. We can take the questions first because I've not seen any on the chat box. So anyone with a question, you can lift your hands so that we give you an opportunity to talk, or you can unmute and ask the questions. One thing I know and has been said is that ovarian cancer is often undetected until it has spread with this and stomach. At this late stage, ovarian cancer is more difficult to treat and can be very fatal. So any question or any comment from the floor?
I have a question.
Yes, please.
Thank you very much for the good presentation. It's very insightful. I just wanted to ask about if somebody is at risk of ovarian cancer, but then they also happen to be postmenopausal, would there be need to remove the ovaries or it is okay? Thank you.
So Priska is asking if there would be a need to remove the ovaries and when somebody is postmenopausal. Maybe Tony can address that.
Yes, well, a good question, Priska. And well, it's a gray area in the terms that even for persons whom you have had a removal of the uterus and the fallopian tubes and the ovaries, the risk reduction is normally, I stand corrected by, I believe, 80%. And still there's that small chance that they might still develop ovarian cancer. So it's a decision that is heavily weighted and discussed with the gynecologist and subsequent steps carefully decided upon. But it would be a good start, but then needs proper discussion and engagement before proceeding the procedure. Because again, as much as you're in the postmenopausal phase, I believe there's still some sense of reproductive function still going on. Necessarily not as before, but still there might be some function that would have to be considered by the attending oncologist. So I would advise a proper discussion before proceeding. And that would be more so for persons with an increased risk, be it a genetic risk factor being the most heavy on this. So I would advise for proper discussions before proceeding. Thanks.
Thank you, Tony. Thank you for that response. I would like to give this opportunity to Jane Francis. Jane Francis, you have a question. I can see your hands up. The floor is yours. Mute and ask.
Thank you. My question is on number one, how can you know that you are developing ovarian cancer? What are the symptoms? Because it seems like there are no symptoms. That's number one. And I'm asking this because I was 8 years survivor of breast. And then last year, I'm being told I'm stage 3C ovarian cancer patient. And I'm just like, when did it grow and how did it even grow? Or was I always ovarian cancer? Because I was also triple negative. So I was not on hormonotherapy, triple negative. And of course, it's gone to the endometrium and all these other areas. So what are the risk factors? Because I didn't have anything that really showed me that I would be developing ovarian cancer. Because after I got chemo at the age of 48 in 2014, the period disappeared, only to appear last year. Question number one. Number two, once now you have this surgery, TSA and BSO, is it a must to do this brachytherapy? And what are the risks of burning your internal organs there? Because it looks very invasive. Thank you.
Welcome, Tony. I think you've had the questions. Maybe you can address them. Thank you, Francisca, for asking about those very, very sensitive questions and very relevant. I like them. However, we have said that the literature says that ovarian cancer is very silent. You may not even know that it is there. And by the time you realize it is there, it's normally very, very, very advanced. And ovarian cancer often has no symptoms in the early stages that you can say that symptoms are here. That is according to literature reviews. But later stages are associated with some symptoms, but they can be non-specific, such as loss of appetite and weight loss, things like that. But Tony, maybe I leave the floor for you. You can elaborate more on that.
Thank you, Pamela. And indeed, sorry for that, Francis. And then, like I said, it's quite distressing when you have already fought a very big fight and won, and then now you have this bombshell being dropped again. And I can understand you being aggrieved and having all these questions. And like Pamela had hinted, and I like what was the theme of this presentation. These signs are normally very, very vague, unless you are actually quote unquote very paranoid about your symptoms. Some patients will not actually get it until when it's too late. So, like she had said, those vague symptoms, mostly abdominal symptoms, discomfort, bloating, you are full all the time, or one spoon and you're already full. You have persistent nausea. And then now you have these, every time you feel the urine frequency and urgency coming in. Those would be some of my top 4 symptoms that would actually tell you probably there's something going on here. And that's what I would like to highlight, if anything, from this talk for today. So are they related, the
Tony,
breast
we are
cancer
losing you. I
and the
don't know
triple
whether
negative?
it's our network,
Well,
which is a challenge.
sorry. So are they
Okay, you
related?
are yeah, it's a little better.
Sorry, Pam.
I was just saying that we are losing you at some point, but I can hear you now.
Okay, at what point did you lose me? Maybe I can try repeat. But I was
Are you
saying
still
the 4 cardinal symptoms I would like to mention that possibly would make you worry. Abdominal symptoms of discomfort, bloating, feeling full all the time. You eat one spoon of food and you're feeling full. Then the issues of you having increased urine frequency and even urgency. I would actually be concerned and seek further evaluation for possible ovarian cancer. Of course, not all the time that will be the case, but it is rather safe than sorry at this point. So you'd ask, are they related? You having the breast cancer before and now having the ovarian cancer? Like we said before, genetic risk factors play a key role in having an increased risk of ovarian cancer. And for particular, what you said was a triple negative disease. We all know, and the oncologists who are here know that triple negative disease tends to come with some genetic mutations as well. And in particular, that they share the same gene, which is called the BRCA, that would actually have put you at an increased risk of maybe having ovarian cancer subsequently. But I don't like dwelling in what ifs, but it has already happened and we are here. Of course, there might be other risk factors. Maybe if you're obese, of course, the age of above 50, and then other issues around there I don't want to probe right now that might have put you at an increased risk of ovarian cancer. Nonetheless, I'm happy that you are getting your treatment and we wish you all the best. So the second question, for patients who have what we call hysterectomy and even removal of the ovaries, you've asked, do they all have to get brachytherapy? Is it really important? And can it injure the internal organs? So we all know that kindly mute that person. So brachytherapy, or what we call radiation to what's the word? Brachytherapy is when you put an instrument that delivers radiotherapy, or those radionuclide material that kills cancer cells directly to a certain organ. And in this particular case, brachytherapy for women, we normally insert it to the vagina itself all the way to the cervix. Normally we are targeting the cervix. Let me just clarify that. And so why do we do that? We do or practice brachytherapy mainly for cervical cancer, endometrioid uterine cancer, and even in some instances for ovarian cancers, when we want to prevent the risk of recurrences, especially to that area of the cervix that is like the, what do I call it? The door to all reproductive system in a lady. Let me just show this photo. So what I mean is the cervix is like the entry point for everything. So once you have removed all this whole area is closed up. We call it a cuff. And so you want to prevent cancer recurrence in the vault or the cuff area. And that is achieved by brachytherapy. So does it have risk factors to the internal organs? Of course, there's some risk factors. For some patients, they get some blood in urine. Some patients, they have difficulty going for long course. They might get some rectal bleeding. And some patients might have a burning sensation and passing the urine as well. And even some local radiation burns in that area. But nothing too serious that your oncologists cannot address. Thank you. I hope I've answered your question.
Thank you, yes. May I ask another one?
I think the network is a bit unstable.
So I was saying thank you for the answers.
Yes, thank you too.
One more question. Can triple negative mutate to ER positive and PR positive? Because I was also told I'm BRCA1 positive. So I'm wondering whether the triple negative mutated to all those positives plus now the ovarian.
Wow. Tony?
Well, I would say in cancer care, nothing is never, like it can never happen. Well, I don't want to say yes or no, but for triple negative, normally, if it's triple negative, we have had some cases whereby you treat a patient for breast cancer.
Please unmute your lines. Please mute your lines unless you are talking.
So it's very rare for it to switch and become the ER/PR positive. But then again, we have had some patients who you have maybe if it was breast cancer and it was that what we call triple negative, and you have metastasis in the liver, and it is a different subtype entirely. So that is possible. I'm not saying it's the case, but it is possible. But I believe some answers you'll not have entire answers to all the questions that you have. But it is a possibility, but a very slim one.
Okay, thank you.
Do we have any other question in regard to what Tony has just has been taking us through? Because just as the questions have been coming on and off, I would still want to repeat that ovarian cancer has warning signs, but the early symptoms are vague and easy to dismiss. Things that you feel, but you dismiss like nothing is happening. Things like even bloating of the abdomen, you will think that most people say, oh, I think I have ulcers. And I know people who have been even treated for ulcers, yet those are those early symptoms. So that's why we are saying it is very silent. And in some cases, some people have experienced some vaginal bleeding post-menopausal. And many things happen during this time. But can you hear me now? I'm saying that ovarian cancer is one of the silent cancers, which you cannot know. Some symptoms come, but you can dismiss them, thinking it is something else, which is not actually the ovarian cancer. But at the time of diagnosis, you realize that it is diagnosed because it has metastasized to other organs. Okay, treatments can be done, and there are several things that happens during treatment. And one of them, which maybe I would have wanted Tony to talk a little about before we disperse this crowd, is peripheral neuropathy in relation to ovarian cancer. Tony, maybe you can say something about peripheral neuropathy as one of the side effects during treatment of ovarian cancer, because it is something which disturbs quite a number of people.
Well, thank you, Pamela. And so for this issue, what we call peripheral neuropathy, or damage to the nerves in the extremities, that would actually give you symptoms of having either numbness in the fingertips or even on the feet. You'd have tingling sensations, or even for some patients, they have these burning sensations as well, which normally appear for patients who have been exposed to chemotherapy, that is either post-surgical or even straight away to chemotherapy. And the culprit is actually both drugs, but commonly one that is called paclitaxel or docetaxel, that are normally very notorious for nervous damage, mostly in the extremities, and it's what we are referring to as a peripheral neuropathy. And it is a nightmare to treat because I think I dare say, and I stand corrected, and my colleagues, and by that senior colleagues are here, I think there's no one modality that has been shown to really eradicate or totally cure peripheral neuropathy. So we have what we call conservative managements, or things that you can do to make the neuropathy either bearable, tolerable, that you can be able to resume to your activities. I know there are some exercises that patients engage in, or are told to engage, that assist in the neuro regeneration and tendency to reduce the neuropathy grade. Additionally, there are some pharmaceuticals or drugs that you can be given to address the same. Though, like I said, nothing is shown to really cure peripheral neuropathy, but there's some interventions that can be done. There are some exercises you can be taught to do, some foods you can eat, some things generally just to ease the burden of peripheral neuropathy, but no cure as per yet. But the good thing is that with time, post-treatment, then the symptoms become a little bit easier and easier to manage and even live with. So I think it's just a matter of time and something to assist the patient before the symptoms isn't, just to live by it and to be comfortable as much as possible. Thank you.
Thank you very much, Tony. Maybe if someone has a question before I continue the few comments that I wanted to put in. Any question? So I was bringing this in because quite a number of clients who are going treatment for ovarian cancer, they tend to present with peripheral neuropathy, and sometimes it becomes very difficult for them to manage it. And thank you, Tony, for elaborating on that. Remember, there are a few things which were mentioned, something like anorexia. Maybe because the audience is both public and for healthcare providers. So you may ask yourself, what is anorexia? It was mentioned, this is lack of appetite or loss of appetite. And also, anorexia is really loss of appetite. No, it's a feeling of whereby you don't want to eat anything, nothing, it seems appetizing to you at all. Tony also mentioned about metastasis, meaning the cancer has spread from one organ to another. So if it was starting at the ovary, by the time you are being diagnosed, it has gone to another organ, then that is what is referred to as metastasis. Sometimes you may come, and because we are used to these words, you hear metastasis and you think it is another diagnosis. It is just that condition, but it has spread to another organ. Also, he mentioned ascites, and also Faith mentioned that she was having swelling of the abdomen. Ascites is accumulation of fluids in the abdomen, which is giving you a lot of discomfort, and the abdomen is swelling. In fact, the first client I saw who had ovarian cancer, I thought he was a pregnant woman, because this somebody was gone post-menopause, and they appear when the tummy is so huge. And that is what is referred to as ascites. And also he mentioned about pleural effusion, whereby there is accumulation of fluid in the chest cavity or the chest region. During treatment, most patients come with hair loss because of the drugs that are being used. They cause weaknesses to the mucous membrane underlining the skin, and those are the ones which hold on to the hair. And once they fall off. And peripheral neuropathy has been talked about, and then survivorship. Then we have navigation. navigation. How or what do I do when I've been I have something which I feel is not normal? Navigation should start from the first place where you present yourself. You'll realize that most people, once they have a problem and they present themselves to a health facility, sometimes us as the healthcare workers, we dismiss them like that is not something serious. So what do we need to do? We need to be well equipped, well informed, and to understand all these symptoms, even at a primary level, the first place where somebody will present with any symptoms, not only ovarian cancer, but any other cancer, so that when we are informed, we will guide them well. But this should go deep inside the grassroots. We also need to get those people, the community health volunteers, they need to be educated on the basic symptoms, things that when people get the symptoms that when people present with more than once, because these are the key people that the government is looking into to identify some health issues in the community and refer them. So if they have this basic information, they will maybe give somebody Actos or Flagyl. They all normally give those ones for any abdominal discomfort. They give it once, twice. They say, if you give it once, twice, and there is no improvement, could you refer this patient to this point? And it should be that the point where they are being referred, they get people who are technically competent to be able to pick that this symptom has exceeded the period of time so that proper diagnosis is made early enough. Most people miss good treatment, not because they have not presented themselves earlier, but because they presented themselves, but whoever they presented themselves to did not navigate them to the right place. Because sometimes somebody comes to me, then I know the next place is a provincial level hospital, or maybe a sub-county hospital. But in this sub-county hospital, where I'm referring the patient, am I referring because that is the protocol, or am I referring because the care that this patient deserves is available there? Sometimes we just refer for the sake of referring. Yet you are referring this person there and the services are not there. We need to navigate people well so that they are referred to a facility where they are going to get the services so that the diagnosis can be made early enough to enable us manage cancer at a very early stage, because early diagnosis is key to cancer survivorship. Those are the comments I have, unless someone has any other comment before I hand over to Charles for the last word. Anybody with a comment or anybody with a question or a compliment?
Yes, I have something to say.
Sorry?
I have something to say. I'm Eva.
Yes.
Thank you so much. I joined a little bit late, but I've gotten so much information, and I really appreciate it. And especially when you spoke about navigating patients to the right referral. So, Mike, I'll take us back a little bit to something that Anthony spoke about a bit earlier, and it's with regard to the link between the BRCA1/2 status and ovarian cancer.
Mm-hmm.
So, from my experience, I did the BRCA test after breast cancer diagnosis and treatment. I was triple negative, had triple negative breast cancer. So right now I'm at the point where we are discussing, double mastectomy to reduce the risk of recurrence, and also oophorectomy to also reduce the risk of ovarian cancer. So my question is, I think this is just for general purposes because I understand my risk because I've already been here. So do you think that the BRCA test is something that we can try and champion to be routine, especially for people whose families have been impacted by triple negative breast cancer, or they have relatives who are BRCA positive? And also, what do you think the impact would be on reduction of ovarian cancer when now we start, when people do prophylactic oophorectomy, of course at the right age, not maybe when they're still young and desire to have children. Thank you.
Thank you very much. Eva, Tony, can you address that?
Yes. Thank you, Eva, for the very interesting questions and even the remarks to the same. And so, question number one, do I think that the population, whether we should roll out the BRCA1 and 2 testing, and what would be its impact on the ovarian cancer, maybe numbers or data? So my thing is, remember when I started, I said, as much as the BRCA1 and 2 have been implicated in terms of having the genetic risk. Remember, most of our patients that we see, I dare say probably 75% will be the sporadic cases of ovarian cancer. But that does not mean that these other small percentage is not important as well. If anything, then you'd find, if you identify these patients who have an increased risks, then we'll be able to subsequently do even genetic counseling and testing for the subsequent family members as well, who we think would be at a risk. Another thing that I said during my presentation, the BRCA testing, if it is positive, then it will give you more ammo in terms of what other treatments do you have for this ovarian cancer. And this brings in case the use of immunotherapies. We have these drugs called the PARP inhibitors. I don't want to go much into it, but they have really been shown that for persons who have the BRCA1 and 2 mutations, they have some added benefit to just the use of the conventional chemotherapy. And even in terms of the side effects or toxicities from chemotherapy, the immunos probably are more tolerable because they are more targeted, quote unquote. So in my opinion, and probably we have other that they called stakeholders in this forum, it is something that could actually look into incorporating into our guidelines. The reason why I'm saying about this is that, yes, we are a low middle income country, but the world is changing very, very fast. And we should not all along cry that we are low and middle incomes, then we should not be doing this. I think we should aspire to have the best of the best for our population. Yes, I know it's quite steep in terms of the pricing, but the good bit, it is available in our country. Then again, with the issues of these what do you call them? Risk reduction surgeries, maybe the double mastectomies and the oophorectomies and the self-injectomies. Then, like I had hinted earlier, yes, the risk is well reduced, but it's still present there. And like you had said at the last sentence, then it should be at that age that the patient is comfortable. And of course, being given both sides of the stories, the pros and the cons. Of course, with a very engaging sitting with the gynecologic oncologist or even the oncologist treating the patient, they have to jointly decide so that once that is done, then there's no regrets towards that. Of course, for the double mastectomies, you can always have the plastics do some reconstruction there. But then again, now for the ovaries, that is really like terminal. But remember, there's other avenues of even fertility preservation, maybe freezing of the of the eggs and all that. So those are other interesting angles that I think as a country should now be discussing with the patient, issues of oncofertility. It's a very novel space that we need to explore more for such unique patients who have confirmed genetic mutations and at a high risk of lifetime ovarian cancer or any other cancer for that matter. So I hope I've responded to the two questions.
Thank you very much. I appreciate perfect response. Thank you.
Thank you very much. And just to let you know, I am Pamela Were. I didn't introduce myself, but I did this one intentionally because I knew there was time was coming for it. I'm Pamela Were. I'm an oncology nurse as well as palliative care. I work with the International Cancer Institute, which is based in Eldoret, and I work here as the Community Chief Outreach Coordinator. We do a lot of activities in the field, whereby we start with screening or diagnostic, linkage to care or advice when the results are negative. And throughout, we just go around, we ensure that we have an end-to-end care for the clients that we work with. We also work with different counties to help them initiate oncology services, because we've realized that many people are not accessing treatment because they're lacking the facilities where to go. So the counties which are like-minded, we help them. We work together with them to mentor the staff, to mentor even the community, the community health volunteers in how we can go through early diagnosis. And there are quite a number of things that we do. We also conduct clinical trials at the International Cancer Institute, both for esophageal cancer, breast cancer, and also sickle cell, and many other things. I'm not able maybe to say them all, but if you reach out to us, you can get to know a lot about what we are doing. I saw Eva, did you raise your hands again, or it is the one you addressed earlier?
So it's the old one. Let me put it down. Thank you.
Okay, so at this juncture, I would also like to thank Tony very much for taking your time and giving us a very elaborate information. In fact, I'm very happy with what you have done, and I know people have learned, somebody has learned. Tony, Jen needs to reach out to you, and maybe you could also reach out to her through your number or through Kenco. I'm very glad that this one has happened. And Charles, thank you for giving us this opportunity. So both of us, we are staff of the International Cancer Institute, but we don't only work for the International Cancer Institute, we work for the entire Republic and the entire globe. Our work is to fill that space in cancer care. Thank you, Charles. Can I hand over back to you? And thank you very much, Faith. I've not forgotten you. It's really hard to get someone who can boldly share the experience the way you have shared. Thank you very much, and keep it up. We need to come up with strong support groups which can help people like that come together and roll back to the normal work in the society. Because some of the people after cancer treatment, what next? You find that some people are just lagging at home, some employers don't take them back. So we also need to look into the survival strategies so that people don't just get discouraged simply because you got a diagnosis of cancer, because it's none of their mistakes. Thank you, Charles.
Thank you so much, Pamela. And I would like to thank our speakers for today, Anthony and Faith. It was quite informative. I agree with some of our participants who are commenting on chat. It was quite an informative session, and it's brought to us courtesy of a project that we are implementing, supported by Janssen Pharmaceuticals. So what we normally do each month for a period of 1 year, this is that month now, is we carry out a social media campaign on a particular cancer, and in this case, it was ovarian cancer. Then we wrap that up with the webinar for the general public and a webinar for health workers. So you can visit our Facebook page to learn more on ovarian cancer. We've been posting messages on ovarian cancer throughout the month. So you can visit there, our Facebook page, Kenco Network, for more information. Just to introduce myself briefly, I'm Charles. I work with the Kenya Network of Cancer Organizations, Kenco, which is the national umbrella body of cancer civil society organizations. We have a membership of around 45 organizations spread throughout the country. And this is one of the things that we do, creating awareness on cancer. So courtesy of our sponsors, we are going to reimburse your data bundles, probably or hopefully in the course of the week. So look out for that. And to wrap that, our Cancer Awareness Month on ovarian cancer, we are going to have a webinar for health workers tomorrow, the same time from 2 to around 3:30. Where we are going to delve deeper on ovarian cancer, the technical issues on ovarian cancer. It's going to be hosted by KNH UN platform. We partner with them in delivering these webinars for health workers. So please, for the health workers who are here, you can please plan to join tomorrow. Next month, we are going to be focusing on leukemia, again, social media campaign. Then we are going to have a webinar on leukemia for the general public and another one for health workers. So you can look for that as well and plan to join us as we seek to learn more and to create more awareness on various cancers. Otherwise, thank you very much for attending our webinar today. And thank you for being an active audience. And I think we are going to post the recording for this webinar in our YouTube channel. So if you want to refer anything, you can check out our YouTube channel, Kenko, and you'll be able to refer. Thank you very much and have a lovely afternoon. Over to you, Pamela.
Thank you too. And I would like to appreciate each and every person. It's always good to take opportunity to join such things because no webinar will leave you without a new list of information. Thank you. And thanks, Charles. Next time, let's meet. Bye-bye to you all.
Thank you. Bye.